afternoon. Thank you for inviting us for this grand round. The surgical management of osteomyelitis requires a multidisciplinary approach. We need the orthopedic surgeon, we need the plastic surgeon, we need the microbiologist to make the diagnosis and identify the pathogen. We need also the hematologist in this picture. We often have a challenge of bleeding in these patients with chronic osteomyelitis. So a hematologist is always handy. And then the physical therapist to rehabilitate the patient. What is the goal of the surgical treatment? One is to isolate the pathogen. Secondly, to arrest the infection, to reduce pain, and then to retain the limb and function. The workup of this patient has been discussed here, but of course, as we prepare a patient for surgery, other additions, we need proper imaging to identify the extent of the bone necrosis. Also, other imaging modalities that Professor was talking about in the acute setting. We do what we call bone scans, radioisotope bone scans. In acute setting, these are able to pick out what we call hot spots. These are hot spots in the case of acute osteomyelitis. If you did a bone scan, you'd be able to pick out the hot spots, and this would settle out where the focus of infection is coming from. Then, of course, laboratory investigations have been mentioned, CBC, CRP, ESR. We, of course, do blood grouping and cross-matching. And then, of course, we need to always consult the hematologist. He has to be handy as we do the surgery. Then we have to stage these patients. As I go in my discussion, we shall discuss a staging system. There are patients who may be having osteomyelitis but may not benefit from the surgery. And then we have to seek consent from these patients before we go on to treat them. My colleague discussed about the pathophysiology of septicemia. Okay, the detail of how it comes to chronic osteomyelitis or acute osteomyelitis, she may be left out a bit of issues. So, how does bone become infected? How do we reach there? Especially in sickle cell, the sickling blocks the major small blood vessels, the sinusoids, especially in the metaphysis of bone. And the metaphysis of bone is where infection begins, just because from the cancerous nature of the metaphysis, the blood flow is slow. So that allows bacteria to easily settle and multiply, coupled with the sickling and then the thrombosis of the minor sinusoids that propagates the infection further. And that kind of characteristics of sickling of cells make osteomyelitis, specifically in sicklers, more diffuse compared to osteomyelitis in a normal individual. So when the infection settles in the bone, pressure builds and then pus forms. This pus, through the Haversian system, that is anatomy that we studied, comes out and elevates off the perosteum. And that's now what we start seeing later on radiographs as a perosteal elevation. Pus from the medullary cavity of bone goes on to elevate the perosteum, and the pus accumulates in the perosteum. The challenge here is we rarely don't diagnose osteomyelitis at this level. we're recently comparing notes, and we compared the number of patients treated with acute osteomyelitis versus the number of patients treated with acute osteomyelitis. And we're wondering why we're not picking out patients with acute osteomyelitis. And the answer was, we always thought and blamed the parents and the attendants of these patients. But I think we realized that the blame also later comes back to us, because we're either treating these patients as a pyrexia of unknown origin and didn't focus on where the focus of infection is. For example, this child presented, a female of 9-year-old, was unable to walk, had a swollen leg, and a high-grade fever. That is already suspicion enough of an osteomyelitis or a septic arthritis. Osteomyelitis and septic arthritis go hand in hand. It is even worse in sicklers. We're discussing about the X-ray there. The avascular necrosis would have been caused by either the sickling process causing thrombosis in the head of the femur, or a septic arthritis that you see when pus accumulates in a joint, the pressure effect causes it to desaturated and to cut off the blood supply to the head of the femur. So how would we treat an acute osteomyelitis? A simple incision and drainage to drain out the pus that could have accumulated in the subperiosteal space. Or we could also do an arthrotomy, since they go hand to hand. The infection could first localize in the hip, then later spread to the bone. Or either way around, from the bone to the hip. So we also need to do arthrotomies. Then we also need to decompress bone. These are part of the ways to make sure the infection doesn't spread to the rest of the bone. How do we compress bone? I think I saw from this presentation a socialization was done. Bone, long bone specifically, is hollow. So we normally create a window in the bone to drain pus and then also to debride the bone. And that is what we call socialization. Chronic osteomyelitis. Two gentlemen, Sunny and Mada, classified chronic osteomyelitis. And they considered two parameters. One, the anatomic type. And type 1 was medullary osteomyelitis. Medullary osteomyelitis is basically osteomyelitis within and limited to the medullary cavity. Type 2 is superficial osteomyelitis. It's unfortunate we don't have power. I would have shown you some of these images. And type 3 is localized osteomyelitis. For example, if you have an abscess within the bone, that's a localized osteomyelitis. Then type 4 is a diffuse osteomyelitis. An osteomyelitis that is beginning, for example, from the head of the femur to the condyles in the knee. And that is the common type we normally see with sicklers, the diffuse type of osteomyelitis. So that is the anatomical type. Then the physiological type, the physiological state of the patient. The class A patient was a good patient with good immune system and delivery. And then the class B patient is a compromised patient locally, local compromise. It could be a venous stasis, it could be a lymphedema, or it could be a patient who's compromised systemically. We are here presenting a patient with sickle cell anemia, patients on chronic steroid use, patients who are immunosuppressed. Those are kinds of systemic suppression. Then class C, these are patients in poor health condition, and these normally don't benefit from surgery. So in working up our patients, we use this kind of classification to stage our patient and then plan for them accordingly. So what are the operative options available for chronic osteomyelitis? We need to do extensive debridement of the necrotic tissues and bone. Here what we are doing a sequestrectomy. To sequester is an English word. This is not science. To sequester is either remove, take away, create peace in an area. So for us, we go to create peace in that area, because the dead bone is not causing peace in that area. I think when the doctor was presenting history, she told us that until the socialization and I&D was done, the fevers had not gone down. So we go to do a sequestrectomy. A sequestrum is dead bone. It's unfortunate we don't have projection. I would have shown you the pictures. So a sequestrum is dead bone. So what we go to do is to remove the dead bone. The dead bone acts as a very good environment for bacteria to multiply, and secondly, an environment for bacteria to evade antibiotics. Because since there is no blood reach to the sequestrum, there is no way antibiotics will reach. Secondly, the other mechanism bacteria use to evade antibiotics is forming what we call a bacterial biofilm. A biofilm is a cluster of bacteria in a matrix, in specifically a dead space, so that they evade the bacteria. So, in situations where you don't have a sequestrum, but there is an obvious osteomyelitis of the bone, what would you do? You do what we call a socialization. Open a window in the bone, decompress it, drain the abscess that is in it, and then wash the bone. And then, after all this, remember you leave a dead space, and you need to manage dead space. Dead space is the source of infection. So how do we manage dead space? We do a couple of procedures. One, since you have taken out a section of bone, you normally left with a defect. So you either do bone grafting or you do what we call bone transport. I wish I had projection, I would have shown it. So bone transport, basically you are cutting part of the bone and moving it slowly to close the defect. Other options are to use, in case of very active infection, you use antibiotic spacers to fill the defect as the infection settles. But then as you do sequestrectomy still, you create a defect and you need to stabilize the bone so that it is not dangling and the patient is easy to nurse. So we do a couple of also procedures. We do what we call external fixation. There are different types of external fixation. We have the Lizarov, which is a whole ring fixator, and you can use that to transport the bone. Then we also need to do a couple of bone and soft tissue reconstruction. Sometimes you're left with a big wound and you need to do either skin grafting or flap surgery. This is when the plastic surgeons come in handy. The other options that are available to us is amputation. You see, as we go to do debridement of necrotic tissue, you end up cutting tendons, end up losing a lot of bone, and when you cannot reconstruct it. So the option that is left then is to do an amputation. So an amputation still suffices in management of osteomyelitis. In conclusion, we need to always have a high index of suspicion. A patient who is unable to walk with high fevers and a swollen, shiny limb is one you should suspect osteomyelitis. And then osteomyelitis in sicklers is difficult to treat and usually involves multiple sites. And then recurrence with osteomyelitis is very common. You see what infection does, it spoils the normal anatomy of bone, creating more cancerous areas where infection settles. If a patient gets a UTI, if a patient gets an upper respiratory tract infection, that infection in the blood, a septicemia, easily settles in areas that were infected before. And then a multidisciplinary approach is required in managing these patients. Thank you so much.
Thank you very much. Can we take questions? Any questions?
Yes.
I wanted to inquire, at what point do you consider performing an amputation, first perhaps in conjunction with cardiovascular surgeons, if you want to achieve curative treatment for a patient with osteomyelitis, since there is a high likelihood of recurrence? Is it possible or is it not?
Okay, thank you. At what point do you perform an amputation? That is your question.
Yes.
Yes? In my goals of treatment, I stated that one of the goals is to restore function of the limb. So sometimes in this, when there is infection, as you go to do the debridements, you end up taking so many things. You either taking away so much muscle, tendons, and then the leg basically, or the limb, is not functioning. So of what use is a functionless limb, which is a source of infection. So that is when we do an amputation. Yes.
Thank you very much. My name is here. My question is, first of all, I appreciate the discussion. My question is, why should we suspect the bone in the first place? What is so unique? Why not? Why do we suspect infection from the lungs or any other system? Why necessarily the bone in the first place?
Okay, thank you. This is what we're talking about. One, you are looking for a focus of infection, all right? And this patient is actually giving you a clue of where the source of infection is. This child is not able to walk. This child has a swollen limb that is actually tender to touch or tender to move. Would you still focus your attention to the liver?
Okay, thank you very much. Let's clap for him.